Welcome to the ACP Cancer of Unknown Primary webinar. I'm Karim, I'm one of the ACP Trainee Committees for Scotland, and we're talking today about cancer of unknown primary. Often known as CUP, is one of those cancers that I think a lot of us don't see that uncommonly, especially when we're on call, but we receive very, very little teaching on it. Often I think it's quite associated with quite sad outcomes and quite emotionally challenging cases, and I think it's important to highlight them. And treatment options have been pretty limited for quite a long time, but I hope that with some big studies and trials that are coming out over the past couple of years, that we'll be able to change that. And it's a real great pleasure for me to present two speakers today. The first one is Dr. Sally Clive, who is a consultant medical oncologist working with me in Edinburgh and in Fife. And her specialties are lower GI and cancer of unknown primary. And she also works on early clinical trials and phase 3 clinical trials at the Edinburgh Cancer Centre. Over to you, Sally.
Yes, thank you so much for the introduction. It's my pleasure to talk today on cancers of unknown primary. I've been team lead for the CUP service in Edinburgh since 2010, when the NICE guidelines were first published, and it's an area that I think we can really add huge value by having some understanding of. And I'm particularly interested in the presentation of CUP, the diagnosis, the pathways to diagnosis, and I'm going to focus on that a bit today. And then Karim's going to talk, Kaikean is going to talk about the more cutting edge stuff for the second half of today's presentation. So I'm going to talk about definitions, pathways, diagnosis. I'm going to include a case history, and then a little bit about standard of care treatments. So what is cancer of unknown primary? Well, there are a number of definitions by NICE, ESMO, and NCCN. We most commonly use the NICE definition, which is based on a histological diagnosis, no primary site detected despite initial investigations and specialist review. And the important bit about that is the histological diagnosis. In clinical practice, however, I think the definition is often a bit different, and so people band the term around often just for widespread metastatic disease. And the NICE guideline helped to address that a little bit by giving a new name for that situation, which is called malignancy of undefined primary origin. And that's in patients who perhaps present to the front door with metastatic malignancy, but they haven't had comprehensive investigations, they haven't had a biopsy, they've not been seen by oncology. Those who've had a biopsy, and it doesn't suggest any primary cancer, but they've not yet had other specialist investigations, are called provisional CUP, and then confirmed CUP. So when we have a biopsy, investigations, and are seen by a specialist. Just a quick word on the pathogenesis of CUP. There's different theories as to why cancers emerge this way. One is that we have transformed cells not growing locally but metastasizing early, finding a favorable microenvironment in a distant metastatic organ, growing in that organ to create metastatic sites, but possibly with different drivers to their growth, different growth pathways, and ending up being pathologically different and biologically different from any recognizable tissue of origin cancer. And therefore, these cancers can have really very unpredictable behaviors and responses, and often grow in an aggressive and unpredictable fashion. And then there's a theory that if you looked hard enough, whether on post-mortem or further investigations, you would find a primary eventually, but that they've got such aggressive biology that they've metastasized and disseminated very early, and that their metastatic disease will in fact reflect the behavior and response to treatment of their tissue of origin cancers. But irrespective of the pathogenesis, these cancers often present at an advanced stage by definition and behave unpredictably and aggressively. The additional thing is that they present in different ways. So metastatic cancer is always bad, but when metastatic cancer presents with a known primary site, often through staging investigations, they have a very predictable pathway, and the information provided to them is pretty standard. Everyone knows what they're talking about. They have nurse specialist support, they have information sheets, and it's a predictable pathway to treatment. Whereas when patients present with cancers of unknown primary, they can literally present to any part of the healthcare system, from GP to front door emergency medicine, to orthopedics, to physios. And as part of that, they can therefore have any number of variable investigations, often far too many of them. There are lots of words about unknown and needing to find a primary can be introduced, which causes huge confusion for patients and family. They can often be referred to numerous MDTs in this thing we call MDT ping pong, where each MDT says not our problem and passes on to another one. But over that time, they may not have any input from their specialist. They may not have any real information about what's going on or any support. And in fact, they may never end up anywhere near oncology or have any palliative care input because their whole life is spent in the diagnostic pathway. And it's really important we're aware of this so that we get involved to modify those pathways where possible. Often our advice is sought early for these patients, as Karim said, often through on-call or acute oncology teams. And often through MDMs, where the outcomes from MDMs can actually be uncertain, or just bounce a patient on to do a further test or go to another meeting, and just result in delays without a patient-focused approach. So how can we help with an oncology? Well, I like to think of these patients presenting with MUO or CUP as three main groups. There's the green, the orange, and the red. The green group are those who hopefully are going to have a good prognosis, have a cancer that's highly treatable, and even some patients might have a curable outcome. There's the middle group that are often classed as the more poor prognosis CUP, who are potentially treatable. They may benefit from treatment as long as they're fit enough. And then there's the patient who, from presentation, are actually going to do extremely badly. They often present as emergencies. They are end of life, not treatable for other medical reasons, or very unlikely to benefit from treatment because of the situation they're in. So looking at the green group from a pathological perspective, this is the good prognosis group. And that I've listed them here. I won't run through them in great detail, but oligometastatic disease, those with poorly differentiated midline cancers, where we have to think about things such as extragonadal germ cell, aggressive not midline tumors or lymphoma. They're poorly differentiated, high grade, and that's high grade, not low grade, not carcinoid, high grade neuroendocrine cancers that can be highly sensitive to platinum etoposide chemotherapy. Of course, the low-grade NETs who can do very well as well, but they're usually now routinely managed by NET teams. And then the cancers that have pathological subtypes similar to known cancers, where we increasingly have molecular approaches to treatment and where we want to identify these patients so that they can benefit from potentially targeted treatments. And I've listed them below: colorectal, renal, or lung-like cancers, or cancers that present as neck nodes with squamous cancer that should be treated like head and neck cancer, adenocarcinoma in females in the axilla, which should be treated like breast cancer, peritoneal disease in women with a serous papillary histology, which should be treated like ovarian cancer, and high PSA with bone metastases in men, which should be treated like prostate cancer. And all of these can do well with treatment, so we should identify them early. The orange group are those somewhere in the middle. This is the majority of patients, and these are classed as the poor prognosis CUP group. And if we get them early enough, and if the patient is fit enough, then they may be amenable to treatment, and sometimes with good benefit. But they have to be fit enough for chemotherapy. And these patients, when they are fit for chemotherapy and they're able to participate in a clinical trial, many trials now have median survival at around 9 months, and about 20% can be alive at 1 year. So even those that are treatable within clinical trials in this group really do very badly. And then the final group, and I list a number of features that help us identify what this group are: multiple organ metastases, poor performance status, pre-morbid frailty, impaired organ function. Importantly, if they present as an emergency with new metastatic disease, there are numerous large-scale audit series that show that median survival is only 30 days in patients presenting with advanced metastatic symptomatic cancer. And of course, if they're unfit for systemic therapy, we know these patients do really badly and they do not benefit from lots of additional investigations. We need to identify these patients and stop investigating. So looking at the green, orange, and reds, we need to identify the highly treatable, get them into oncology quickly, and discuss treatment options with them. We also need to identify those possibly treatable and identify those who are treatable in this group, and again, try and get them through that pathway quickly and urgently so they can get quickly to treatment. And finally, we need to identify that red group, those who are going to do very badly or who are not fit for treatment. And we mustn't just recommend routine tests for these patients. We should stop investigating and actually have honest, open discussions about what's best for that patient, which is usually symptom management and honest discussions with shared decision-making. And very importantly, we must remember that we can move quite quickly from green to orange to red groups if we don't have rapid diagnostic pathways, because these cancers, by their inherent biology, behave aggressively. And we don't know the number of patients that never actually make it through to our MDMs or to our clinics because they fall off whilst they're being worked up through other teams, sometimes on our advice or our MDM advice. I'm not going to talk in detail about this, but the sort of investigations we must remember are a good clinical assessment and a basic physical examination, including things like rectum, skin, breasts, testes. Judicial use of bedside tests, including routine blood tests, and of course CT in most patients is indicated. Only endoscopy as directed by symptoms or other features, and PET only in very limited indication, for example, oligometastatic disease or squamous cancer in cervical neck nodes. Biopsy then is, of course, important in many patients, but we must remember that it's only important if the patient is going to survive long enough to get the biopsy, to get the result of the biopsy, to have it discussed in a meeting, to be seen in a clinic, to start treatment, and then to have time to benefit from the treatment. And we remember that a lot of patients who are admitted as emergencies are never going to survive long enough for all of that. So we have to be considerate about who we biopsy. We don't have to biopsy everybody, only when a patient is going to survive long enough to benefit, and only if the result will influence management. When a biopsy is appropriate, it is of course quickest to biopsy the sites of metastatic disease rather than try to chase a primary and biopsy that. And it's helpful to provide the pathologist with as much clinical information as possible to help guide their analysis. And we must chase up that result and get it discussed very quickly and promptly through MDM, through a CUP meeting, to try and make sure we get a diagnosis quickly for the patient, to get them started on treatment if they're fit for treatment. So to highlight the reasons why it's so important to take patients quickly through the pathway, I'm going to discuss the case of a real patient who came through our MDM. This was a 65-year-old woman presented as the MDM as previously well. She'd been referred from our colleagues in sarcoma MDM with a new lump in her chest wall, which was causing her increasing pain. We were told the CT showed a large mass with an unknown primary, and the biopsy showed a poorly differentiated carcinoma, which was not a sarcoma, not a lymphoma. The surgeons didn't feel was going to be easily operable, and there was no obvious primary detected on CT chest, abdomen, and pelvis. So we discussed her scan, and as we can see here, we can see this large lump at the right side of her sternum. It was eroding the sternum, destroying the costal cartilages, bulging into the thoracic cavity and distorting the pectoralis major. So this seemed like an oligometastatic picture. It looked like this should fall within our good green group of treatable cancers with possibly a good outcome. And we looked at the pathology. This showed a metastatic, poorly differentiated carcinoma with lots of negatives. It wasn't lots of things. And the only thing that was positive was CK7 positive, so cytokeratin positive, showing a carcinoma. So a review at the MDM, the sarcoma team had already said it wasn't sarcoma and wasn't operable and referred to our team. And we thought we should request some additional molecular testing. We should organise a PET scan as it's single-site disease, and we're thinking about radical treatment, and an urgent oncology appointment was arranged for 2 days later. But when we met the patient in the oncology clinic, the patient was completely different than we might have expected or anticipated from the MDM discussion. This patient was in significant pain now, had extreme fatigue, had lost significant weight, was spending her time mostly in bed, performance status 3. We brought her straight into oncology, and admission bloods showed her to have a very low sodium, low albumin, and very inflamed picture with a high CRP and white cells. We started on high-dose steroids. We gave her some radiotherapy to her sternum. We got the metabolic team to help us manage her sodium carefully and slowly, and we gave her broad-spectrum antibiotics to try and reverse everything we could think that was easily reversible. But unfortunately, her condition did not improve at all, continued to decline very quickly. We had lots of important and new conversations with the patient about cancer, about its meaning, and about the fact that things were going rapidly downhill. And eventually, with no improvement in her situation, we agreed to focus on comfort care, and she died very quickly during her inpatient admission. And this is obviously very sad, and I think it helps to go back and look at the pathway again. Oh, towards the end of that, just before she died, we got the molecular pathology back, which showed that there was nothing that was targetable or treatable. But of course, by then it's really irrelevant. So going back and reviewing the case history, so she presented at the beginning as a fit 65-year-old with a pain in her chest wall. She'd gone to the GP. GP did a chest X-ray, it was normal. Referred her to the breast clinic. They did mammograms, they were normal, sent her back to the GP. At week 3-4, she had worsening pain and now felt a lump in her chest wall. So went back to the GP. GP did a sternal chest X-ray with sternal views. It was reported as normal. So referred the patient back to the breast team. Meantime, the patient had worsening pain and worsening fatigue and presented as an emergency to the front door. They did a chest X-ray, reported as normal. They gave her analgesia and they booked an outpatient CT. But on the CT request, the information was breast lump. So the radiologist cancelled it, saying CT is not a good way at looking for breast lumps. Her breast clinic review came up. She went back to the breast clinic. The breast surgeon felt a palpable lump, but said it's not breast cancer, and rebooked the urgent outpatient CT. Meantime, the patient had worsening pain and now is increasingly fatigued with a declining performance status. Went back to the GP. GP now refers the patient up to the front door. The emergency medical team bring forward the CT as an inpatient. The CT gets done. They don't know where to refer it. The family are starting to get distraught, put a lot of pressure on the medical teams. They find an MDT to review it. The sarcoma team reviews the CT scan, arranges an urgent biopsy. The biopsy shows poorly differentiated carcinoma. They discuss with the surgeons and they send to the CUP team. And we're now at 2.5 months from her first presentation, when she gets discussed at the CUP meeting and 2 days later in the CUP clinic. And we're now actually at the end of this lady's disease trajectory. By now, this cancer has taken an enormous amount out of her, and she's no longer the fit lady she presented as. She's now performance status 3, very symptomatic, with extremely deranged biochemistry and an uncorrectable situation, and died shortly after. And so the importance of this story, I think, is to show that the cases we get presented at MDTs only tell a really small part of the story. And what's really important is to see patients, to take patients through the pathway, to keep in touch with them, to understand if their clinical condition is changing and change course accordingly. What lessons can we learn? Well, I think we should own the patient's pathway to diagnosis, and sometimes oncology has to be part of that. We have to continually reappraise the clinical situation. As I said, patients can go from green to orange to red before our eyes. Rapid pathways are really important. We need to prioritise the important investigations, not get stuck doing investigations that are not going to help progress the patient's immediate management. And we need to introduce early, honest conversations, set expectations, and allow time for preparation for the patient and their family to enable shared decision-making about next steps. So looking at our patients, we have a database in our Edinburgh MU CUP team of all the patients referred to our MDM, and we looked at 1,225 patients discussed at the MDT, and out of them, a quarter of them were too unwell, too fit, too frail, too comorbid to benefit from a biopsy. So that was about a quarter, and they remained as malignancy of undefined primary origin. 73% did get a biopsy, but of those 56 individual patients, never made it to an oncology clinic or oncology treatment. So arguably, they should have remained as MUO. They should never have had their biopsies, either because they were never fit enough for treatment or their condition was deteriorating so quickly they were never going to get to treatment. 8% didn't have a cancer diagnosis. Just over a third, we actually managed to identify a primary and refer them to that team for treatment. And a quarter remained as a confirmed CUP for management within the CUP team. And looking at the survival of these groups, we can see that obviously at the top, the non-cancer diagnosis did well. Those in whom a primary cancer was identified did better, although still not very good when they present with advanced metastatic disease, with only 36% still alive at a year and a median survival of 8 months. Confirmed CUP, median survival in this real-world evidence group, 4 months, with 20% alive at a year. So that's kind of similar to the original trials that are often quoted for old trials. But MUO and CUP, that's patients who at the beginning are not fit for a biopsy or get a biopsy but never get to oncology, do incredibly badly, with median survival of only a few weeks and very, very few getting to a year and only a quarter getting to 3 months. And that's really important to remember so that we manage these patients accordingly and talk to them about a cancer diagnosis appropriately. So how can we predict who's going to do well, who's going to do badly? How can we predict which ones to get quickly into our oncology clinics, to get into clinical trials, to give cancer treatments to, and to help benefit from all the new and exciting areas we've got going in oncology? Well, we know that good prognostic features include the green group that I described earlier. That's the favourable clinical pathological subgroups. Those with single site or single organ disease often do better. Those with good performance status of 0 or 1 and who are fit enough for treatment. And poor prognostic features are those who present as an emergency presentation with advanced metastatic disease, who've got a performance status of 2 or more, who've got an inflamed picture with white cells high or high LDH, and who've got multiple metastatic sites, including liver. In Edinburgh and with the National CUP team, the CUP research group rather, we've looked at prognostic biomarker scores using simple objective blood tests. We've looked at the Glasgow prognostic score, which scores people according to their CRP and albumin. And you can see here that a CRP more than 10 and an albumin of less than 35 counts as the worst score, which is a GPS of 2. We've also looked at the Scottish Inflammatory Prognostic Score and neutrophils of above normal with an albumin of less than 35 gives you the CIP score of 2, which is the worst prognostic score. And we validated these in over 1,000 MUO and CUP patients. And what we found is that patients with either a GPS 2 or a CIPS of 2 do worse in all cancers of unknown primary and all malignancy of undefined primary origin, irrespective of histopathological subtype. So these are quite strong and helpful prognostic markers, and when combined with performance status can be quite powerful in helping identify those who are going to do badly. So looking at survival in 1,000 patients from our database with MUO or CUP relative to their Glasgow performance score, you can see here, Glasgow prognostic score, you can see here that those with GPS of 2 are the bottom line in this chart and do particularly badly with a median survival of only at 1.6 months. Whereas those with GPS of 0 do much better with a median survival of 8 months and a significant range with quite a lot of longer survivors. And looking in a series of patients with confirmed CUP diagnosed through specialist CUP teams across the UK, over 500 patients, we looked at the Scottish Inflammatory Prognostic Score and again showed that those with a CIPS of 2 did much worse, and a CIPS of 0 with a non-inflamed picture in their blood did significantly better, irrespective of pathological subtype. So, summary of good prognostic factors: performance status 0 or 1, non-inflamed picture, single site disease, nodal disease or single organ visceral disease, and the favourable clinical pathological subtypes can all indicate a good prognostic factors, particularly if you have all of those features. So going back to our 3 main groups then, we've got our pathologically guided good prognosis or poor prognosis CUPs, and then we've got the group that are very unlikely to benefit from treatment. And we've got the patient factors such as their performance status, their inflamed status, the extent of their metastatic disease, and their baseline health. And then we've got their biological features, their cancer behavior or growth rate, and their things like their molecular genomic characteristics, which can help direct treatment when they're fit enough for treatment. So what therapeutic strategies then do we have to treat patients with confirmed CUP? Well, there are three strategies, and I'm going to focus on the first one in my talk. I'm going to leave the more exciting parts to Kai Keen for the second part of today's talk. But there are empiric SACT, which is the standard empiric platinum-based therapy that we give for cancers of unknown primary. There's also this therapeutic strategy of trying our best to identify the most likely tissue of origin through immunohistochemistry, morphology, molecular pathology markers, to try and identify treatable cancer types, and then using treatments aimed at the most likely primary cancer site. And I've identified some of those groups in the green group shown earlier in my talk. And finally, there's trying to identify therapeutic targets, either instead of or as well as the standard chemotherapy. And we've got some exciting work that Kai Keen's going to talk about today, later in the talk. So focusing on empiric SACT, well, for years and years and years, that has been the backbone to all clinical trials in cancers of unknown primary. Numerous trials done up until the 1990s, many thousands of patients. Most of them showed a median overall survival of about 5 months, with about 20% surviving to 1 year. No one regime came out of that group of drugs, many different types used, nothing coming out as preferable to any others. From the 1990s onwards, most trials focused on either carboplatin plus paclitaxel, cisplatin or carboplatin plus gemcitabine, or 5-FU and oxaliplatin or irinotecan. And in these trials, with a more selective patient groups, median overall survival was now more commonly quoted as up to about 9 months. And some trials had as many as 39% surviving to 1 year. And there's always a few long-term survivors with the more highly treatable subtypes. But out of these, no one single regime is preferable. We tend to use the oxaliplatin and 5-FU for more of our GI CUPs, but other than that, no one treatment type has come out as better than others. What has been shown is that empiric targeted agents such as bevacizumab or erlotinib plus SACT were no better than SACT when used empirically without any directed treatment. So in summary, most trials show median survival about 9 months. And remember, these are patients, all of whom are suitable for clinical trials. So by definition, performance status 0 or 1, and expected life expectancy of more than 3 months, and fit enough to come to an oncology centre and be treated within a clinical trial. But no real superiority of any one regime when used in an empiric way. And these are the sort of regimes that we use, summarised here, and the sort of patients and benefits of each treatment regime. But essentially, we use doublet platinum-based chemotherapy as first-line treatment in those patients who are fit enough for chemotherapy treatment. And we choose the regime based on patient features as well as clinical pathological features. So my final slide then, just an overview of everything we've talked about today of standard clinical management of patients presenting with cancers of unknown primary. So patients with confirmed cancer and no obvious primary after specialist review, well, the first thing we obviously always do is exclude a non-CUP neoplasm. So exclude such things as lymphoma, myeloma, sarcoma, and extragonadal germ cell. We, of course, have already excluded those patients not suitable for investigations or treatment, either because of clinical patient factors or performance status, inflammatory score, comorbidity, or patient wishes, which is always important. For those, we then look to see if they've got one of the 10 to 15% of patients who have favourable risk CUP, and these are the green group that we talked about earlier with specific pathological features, in which case we treat them like their parent cancer and send them ideally to those cancer teams for treatment, where they can benefit from sometimes from targeted approaches to treatment and targeted drugs. But for the majority, which is the 80 to 85% with poor risk CUP, We then identify if they've got good performance status, if they've got a GPS or SIPS that suggests they're going to do well, and if they're fit for treatment and wish to consider it, then we would consider 2-drug platinum-based SACT combination treatment, hopefully inclusion in clinical trials where we can, sequencing and profiling if we can, but always remember to include supportive care, symptom management, because many of these patients are not going to do well. We know that the median survival is still less than a year, and for many patients, treatment's just going to buy a few extra months, and we still need to continue the discussions about best supportive care. And in many of these patients, they won't be fit enough for treatment, or treatment will be unlikely to benefit them much, and they may be better served with the best supportive care approach, and they certainly should be part of the shared decision-making about that. And that's my final slide. So I'll pass over to Kai Keane, who will now talk about the up-and-coming and new strategies we're using in cancers of unknown primary, which is where it's all happening. Thank you.
Well, again, so thank you. Well, thank you, Sally. Well, thank you, Karim, for inviting us. And I can see there's quite a few names, at least on the chat box, I recognize, consultants and trainees. So really happy to talk at this important webinar, and Sally for introducing beautifully certainly the diagnostic challenges and management of CUP, MUO-CUP. And now, I guess, yes, we're going to talk about the CUPISCO trial, which is a very interesting phase 2 international study, and some CUP updates. You know, what are we going to do with this trial data? What are we going to do in real life in the clinic? So I'm Shiu. I'm a GI medical oncologist, but I also lead the CUP service, and I used to lead the AO service as well. So certainly seen the really bad side of how patients present with disseminated malignancy, and when we make big decisions. And I've seen one question already from Andrew, and we'll certainly answer that in the chat box later. So let me see when this goes through. Okay, I think we should start with this slide, which is a really nice combination slide by John Simmons, who's an amazing guy who set up one of the first and remains only of the few support groups for patients and families living with CUP. So first of all, you know, what do patients really want? Okay, and you know, they're a kind of hidden kind of group, aren't they? Because I think Sally's already said that CUP is not actually that rare. Okay, it's just hidden amongst many MDTs. But the double agony of a patient being told, you know, on the ward, or even if they get to clinic by oncologists, that, you know, that you can't find the primary, you know, how come, you know, and why does the oncologist not know? I mean, after many, many weeks of, you know, even tests, why do we not know? And of course, the standard anxiety, because most CUP patients have got, you know, metastatic disease, how long may live? You know, there's a kind of social aspect, psychosocial bit of it as well. And, you know, there's uncertainty, because you can't say, I've got breast cancer, I've got stage 4 bowel cancer. What does that mean? And on the other side, we should just remember there's certain, you know, general core things that any patient would want with bad disease. They want to live, don't they? They want to ideally live longer, and yes, ideally with good quality of life. They've heard, you know, that chemo isn't the best thing, you know, radiotherapy might help a bit, but they've heard about probably targeted treatments, certainly immunotherapy. They want targeted treatments. And some of them certainly want to participate in research and trials, or at least feedback on that. And we are, as oncologists, enablers, you know, and then we need to get the rapid referral. I'm sure Sally talked about the fact that we cannot live in our ivory towers. You know, we need to be helpful to other referrers. And actually, if you become an AOS or CUP specialist, you have to embrace uncertainty, and you have to embrace that it's a bit messy. But as you'll see, that if you do pick these patients up quickly, and you do have a good CUP team or AS team, you can make a big difference. I'm not even talking about whether you get them in a clinical trial. You're just talking about giving good advice, communication, and getting the appropriate tests as quickly as possible. Okay. And as Sally said, all the time, in general, early, holistic, supportive, even indeed palliative care, because all these patients are quite symptomatic. And I think the other kind of difficulty I've certainly had, and I am in a slightly different situation at UCL because I'm very lucky where I work, and Sally works in a big center, we do have access to genomic profiling, okay? And we can get that funded relatively easily because of the service where we do CUP. even if I've seen patients who self-fund profiling, it's kind of easy to profile a tumor technically, even with blood biopsy, and we'll talk about ctDNA. The more difficult thing was it the right profile. So I've certainly seen patients profile using some kind of assay, which probably wasn't the most appropriate one. It was very expensive. And even if you find the alteration, fine. Can you find a match treatment? The next thing is, well, okay, even if you find a match treatment, how do you access that treatment? Is it going to be a clinical trial? And there are very few clinical trials for CUP patients. Or can I use, another trial that accepts subgroups of CUP patients, or self-funding, unfortunately, or compassionate access? And then after all that hurdles, the main issue is, will I respond? Well, I hope they can, and they do. And can we speed up that process and learn, or get access to studies that will speed up that whole pathway? And I'm going to discuss a case which is not quite as sad and bad as Sally's, but still has some really lessons about what patients want, even if they're on a clinical trial and they're doing well. And it's all about quality of life, actually, and indeed convenience. Okay, they want to have a convenient treatment closer to home. That's what I think. Now, just before I talk about the CUPISCO trial, and then many of you have dialed in to listen to that, and I will try and summarize that trial, I just want to kind of echo what Sally has said. If you have a good CUP MDT and you do slightly separate out true CUPs, and obviously if a true CUP patient has managed to go through a whole diagnostic cycle, they're probably fit for treatment, and therefore if they're fit, P is 0, 1, even 2, they should be accessible for clinical trials. I'm just going to show you one bit of information that one of my oncology SHOs presented as a webinar a few years ago at the NCRI, which was just showing ever since 2019 to 21, that's essentially 3 years, we had 139 patients referred to our CUP MDT. That may be many, that may be few, depending on where you work. I think it's actually quite few, but because we winnowed out a lot of referrals from secondary care or primary care through our oncology team or other MDTs, but actually not that many had true CUP. Having said that, we had MUOs, we had provisional CUPs, we had no cancer identified, and we had a real range of ages, 27 to 98, okay? Now, of the ones who are given treatment, I think that's really important. There are patients who are just not fit for treatment or don't want treatment. And yeah, of course, you could say their prognosis is going to be bad, either their choice or the clinician's choice. So really, you can't really include that in all comers. So let's just talk about ones who are given treatment. The thing that's changed, and I'll show you because we recruited many into the CUPISCO trial, which I say, is that it really has changed what we can do. So in terms of 1 year survival, we've gone up to 58%, whereas if you look at the statistics, it's about 16%. Okay, but that takes all people who have got MUO, CUP, have no treatment. And the median overall survival, though, to be honest, this is a short follow-up, is around 13, 14 months. And just remember that month data, because I think this is a mix of what I call technically good prognosis CUP and bad prognosis CUP. And we hardly treated any what I call good prognosis CUP because they went to the sites of excellence, the lung, gynae, GI, whatever. But what I want to show you in this table is that, yeah, we had quite a variety of treatments. But the really interesting thing here is that this number 9, chemotherapy plus or minus targeted immunotherapy, was driven mainly by the CUPISCO trial, which I'm going to show you, which is this novel trial trying to get novel treatments into our CUP patients. And even before I show you what the CUPISCO trial shows, is that we learned so many things from the CUPISCO trial. And one was just to update the guidelines for CUP from ESMO, which have been updated for ages, okay? So Sally's already kind of discussed some of this, but I think it still shows you that although, yes, we've got these favorable prognosis CUP, there's still only 10 to 15%, so 1/6 of our patients. And the vast majority are poor prognosis, but if they're fit, they should have platinum-based chemotherapy. If they're not fit, that's what we care. But yeah, we should try and get them into clinical trial. So I've put the reference there. These slides can be PDFs and shared later. So that's an important ESMO CUP guideline that's just been approved earlier this year. Now, this is the presentation. So I think we should be proud as a UK nation. We started, I think, off of 6 sites. I was the chief investigator for the UK. And we recruited so well, and we showed the other countries that we did it well. They actually gave us more sites. So I think in total we ended up with 10 sites across the UK, including Edinburgh with Sally and including Villandre in Cardiff. And we were, I think, the second highest recruiting country in the world. And between me and Natalie, at least, we were the fourth or fifth highest recruiting site in the world. So I think we have to thank everyone who referred patients to the sites. Also, we should be proud as a nation that we managed to contribute to this very important study. So Linda Miniskin, who's a fantastic gynae CUP oncologist in Australia, was the first author, and luckily Natalie and I were co-authors, and Alvin Kramer, who's from Germany, is a hemato-oncologist with a specialist interest in CUP. He is the global chief investigator. So we presented this at ESMO this year as a late-breaking abstract. So I'm just going to show you 6 or 7 slides. It was quite a long slide deck, and hopefully we'll spend a bit of time going through this data. So I think the first thing you see is just a pretty busy slide. Okay, so I'm going to just say in basically what happened was they put good performance status, which is rare, right? PS01, bad prognosis CUP patients. So none of them were squamous cell. We felt they had good responses to platinum-based chemo-rad. They weren't gynae-like, they weren't breast-like, they weren't prostate-like, and they weren't colonic-like. So they got a lot of referrals of, why can I not do this patient? Well, you'll see the chemo protocols we were giving were platinum-based, but not GI platinum-based. So there was no FOLFOX or CAPOX, which a lot of us use, right? So they were not GI-like. And the reason is, for colonic GI, is that actually you can treat an unknown primary colonic, and they do pretty well on FOLFOX and sequential FOLFIRI and things like that. And we didn't want those kind of patients. So in here, the key eligibility are unfavorable non-squamous CUP. They were centrally confirmed. And again, this is the really important thing. And it was quite helpful for some of us and our patients, because we sometimes were pretty convinced that they were a CUP. And then they said, well, let's check. And they would actually get tissue from us, obviously, because we would send it. They would have their own kind of molecular board. And certainly, I don't know for Sally, but Natalie and I had a few sarcomas, actually, which we're a sarcoma center. So I kind of had to kind of go back and said, actually, this was a weird sarcoma or some kind of urothelial renal cell cancer. So it was actually quite helpful. Standard things about having measurable disease, but we definitely had to have tumor tissue, which is tricky, remember, in CUP patients to get, and blood, which is easier to get to do this foundation medicine profiling. So I'm sure you've heard of it. It's a commercial test. Foundation 1 CDX looks at over 355 genetic mutations and looks at TMB and MSI. So it's not the most comprehensive test, but it's a well-known test, and we use that. And the other thing I'd say is that the drugs you'll see on the right, and there's a busy slide, vast majority are from Roche, because Roche actually funded the study, but you also see there are drugs there that are not, by Roche, and that's important. We managed to get other companies to give drugs which were not justified as a company. So spent a bit of time on that. I think the thing you've got to realize is that we screened a lot of patients, right? So we screened 1,500 patients around the world, and a lot of them failed. I'm not going to go through the reason of screen failure, but most of them were because actually they weren't CUP, okay? We enrolled over 600 patients. A few didn't start induction, which just shows you some of these patients just weren't well enough to start, but the vast majority all received 3 cycles or 9 weeks of induction platinum. So you had 3 choices: carbotaxol, cisgem, and carbogem. Just remember, these are lung-like protocols. So when I say cisgem, there's not cisgem like cholangiocisgem. It's high-dose cisplatin on day 1 and gem on day 1, day 8, similarly for carboplatin. Now, it's really interesting here. So you look at the numbers starting going down in induction periods. So 58 people discontinued by the induction. Why? Probably because they were really unwell. They had too many side effects, and either they or the physician did not feel they were well enough to come into the next period. But that's pretty good. So that's less than 10% of the patients, So then you've got a group of patients who are what we call category 1 and category 2. The way that it worked was that category 1 were patients who had achieved either complete response, partial response, or disease control, stable disease. And they were the ones who would be randomized 3-to-1 to molecular guided therapy based on the foundation test or continuation of chemotherapy. So if you just look at that category 1, that was driving the progression-free survival endpoint, okay, which I'll discuss in a second. But when you're randomized 3-to-1, that's pretty generous. Okay, that means that 3 out of 4 patients will get randomized to a guided therapy. And you can see 9 different targeted treatments and what I call the non-targeted treatments, which include atezo, which is immunotherapy, or atezo plus chemotherapy. We won't talk about alternative therapies. There were other discussions sometimes where patients from their profile, they were actually found to have a drug that was not eligible, was not on the trial, and they were allowed by sponsor approval to have a treatment that wasn't driven. But the way that the progression-free survival, which was the primary endpoint of this trial, was basically that the combination of category 1 patients randomized to molecular therapy would be significantly better than the ones who continue chemotherapy. The second thing to remember is the time from progression is from the time of randomization. So the months I'm going to give you when I show you do not include the 9 to 12 weeks of treatment in induction. Okay, so you've got to add that onto your overall PFS, particularly in category 1, because they have all responded initially to chemotherapy. The important thing is that I think ethically it was very nice that really they included a category 2. Okay, category 2 is patients who progressed on induction chemotherapy. And if they were fit enough, if they felt the investigator were fit enough for targeted treatment, they would go through their molecular tumor board and still, based on their, if they felt they were fit, they still get non-randomized targeted treatment. So there's a small number of patients that was not presented at ESMO, but it is something that we will present in a future paper, and we are submitting this for publication in a high impact journal. So primary, just going to go back, primary PFS, and I was just looking up from the paper, the PFS was based around a hazard ratio of 0.7 with an alpha of 5, two-sided 80% power, and we needed about 330 events out of 400 to hit a PFS, which was better than 5 months. Okay, so we felt that 5 months PFS, okay, it would have to beat that. Okay. Now, this is the demographics and benefit characteristic, which is really important because this is a clinical trial, and you could argue, is this what we really see in the clinic? So median age 61, 62, I think that's about right. A pretty big range, 24 to 84. Male, female, similar. These are good performance status patients, okay? In general, yeah, 0, 1, and over half of them were 1, okay? So the third was 0, 2/3 were 1. It's very interesting that, I mean, carbotaxol I used, but I didn't use so much because obviously I'm more of a GI oncologist, but it is a pretty powerful regimen and it's pretty toxic as well. And it's interesting that over half the patients did get carbotaxol, probably proves either the strength or the fitness of these patients to have it. But equally, what the investigators are used to giving in their kind of CUP centers. So vast majority got carbotaxol, a third of them or quarter got the cisgem, and I would say carbogem was the gentlest treatment. Okay, so obviously I did treat some of my more frail patients with carbogem, and yes, about 1 in 6 of them had carbogem. The other thing which I thought was very interesting, which is this reality, and I would like to comment from the audience, is I think this is pretty amazing, actually. So remember, these are the patients who did respond, okay? But if they did respond, okay, then it looked like there was either complete or partial response in over a third of the patients and stability in the other 2/3. Now, you saw the drop-off in the thing that actually it was quite amazing, because normally when I talk to a patient with a CUP, I actually kind of say a 30% chance of any response, okay, and maybe some stability. So this is a complete reverse around, yeah. But remember, these are fit patients in a clinical trial. Now, this is really important as well. We had this molecular tumor board. So once the patient had gone through the induction chemo and they had stable disease and they wanted to then access the MTB, the only group of patients who didn't access the MTB were the ones who were randomized in cohort 1 to continuation chemotherapy, because everyone else had the ability. And it was quite an interesting process where you kind of had to have an appointment, you dialed in, and there was yourself, there was the team in Basel in Germany, there's a pathologist, there's the oncologist, one of the senior oncologists from the TSC, and we had a general chat. Now, we also kind of was quite clear sometimes what you are going to choose. Okay, so remember, although we've got lots of options based on the FM1 test, actually most of the genetic alterations don't match. Okay, so you've got to remember that the chance of hitting one of these targets was EGFR, HER2, BRAF, PIK3 kinase, BRCA, FGFR, eventually IDH1 and things like that are actually quite rare. So the weird thing was that, yeah, if you hit BRAF, let's go. We would give them BRAF target treatment. If it was HER2, let's go, give them HER2 target treatment. But the vast majority hit the bucket, which was there was nothing. There was no TMB high, couldn't get atezo by itself. So it was actually chemo plus atezo. And I must have had skeptical at the beginning. I said, what's the ability of just adding atezo to chemo? But we do this all the time now, right? In an biomarker selected way with lots of cancers, gastric cancers, lung cancers, and GU cancers, well, recently to GU cancers. So I think it's just important to say that there's lots of different options, but actually once you kind of sit down at this MTB, it's very clear there's only probably one or two options in terms of targeted treatment. I just want to go back actually. So if you actually look at the numbers of patients in this target, you can see it's pretty low. So alectinib 1, erlotinib 3, entrectinib 0, so no one for entrectinib. A lot in HER2, quite a few in BRAF, and a huge amount of olaparib, that's BRCA, atezo, and then this huge group, over 200 patients who got atezo plus chemotherapy. Now, here we go. Here's the primary endpoint. And just before we just go over that, remember, this is an event-driven study, and this is PFS driven with that hazard ratio of 0.7. So the p-value is 0.007, but if you kind of go, is it really, MGT 6.1 versus 4.4 median PFS? That's 6 weeks difference. Of course, that doesn't look so impressive on the face of it. But remember, this is what I call a group, the whole group of patients in the targeted treatments. And we know some targeted treatments are going to be maybe life-changing, particularly if you're TMB high with atezo, and others we don't know whether, if you've got CUP with BRCA or CUP with HER2, does pertuzumab Herceptin work? I think the other thing is this is a randomized trial. It's the first randomized trial of this kind in CUP that has shown any survival benefit at all. Okay. And you've also got to remember, you've got to add in those kind of 3 months on top of that. So actually for the molecular guided group, it's, 3 months of 2.5 months of chemotherapy followed by MGT. So your PFS is already heading towards 8-9 months, which is already beating the 9-month OS for good prognosis CUP that Sally has shown. Okay. Now, we also were skeptical about the benefit, as I just said, of giving just atezo onto chemotherapy without any biomarker, and we were correct, because if we actually remove the chemo atezo group and just leave the patients who had targeted treatment to ALK, HER2, BRCA, TMB high, you can clearly see a much better PFS. Okay, so the PFS excluding atezo chemo now becomes 8.1 months. Okay, atezo you can see really doesn't add a huge amount, 5.5 months over 4.4 months. So again, just shows you that the truly targeted patients had a good outcome for PFS. In terms of side effects, I would just generally say it's a kind of slightly weird way of kind of reporting this because it's all a bit numbers driven. But I think the main thing is that we're saying is that patients who had a targeted treatment after induction chemotherapy had far less AEs than the patients who had to continue with another 3 cycles of GemCis or carbotaxol. So went for 3+3, obviously they're going to have more side effects. There's another coming around the back end is obviously some of these patients who had targeted treatment went on for a long time and would have had some AEs due to their targeted treatment. But in general, you can see the numbers of related AEs, withdrawal from treatment, dose modifications, serious AEs, and certainly grade 3-5 AEs, far less in the molecular guided subgroup. So quality of life has not been formally analyzed, but you could argue that if you've got less AEs, probably your quality of life is better on a targeted treatment than chemotherapy. So here are the secondary exposure endpoints, which really we need a bit more time to look through, and certainly OS is an important endpoint that we need to follow through. It's an event-driven study, so we probably won't know OS for at least another 9 to 12 months, okay? But in general, I just want to show, of course, response rate. There was a general in favor response rate to molecular-guided therapy, 17.8% versus 8.2%. Remember, this is in the after induction, okay? You've got to respond beyond induction. Look at this. I think this is pretty impressive. Duration response, 16.4 months. And then quality of life, I think, is difficult to know because I think we haven't really looked at proper health-related quality of life. And that's a big thing, which I'm sure Sally and I can discuss later, but we were discussing that if this ever goes to NICE, you know, they're going to look at quality of life here. I think we're just going to say that we don't quite understand what the effects of molecular on duration response yet. We don't think there's a big difference in quality of life. And there's a trend, okay, to better median overall survival. So 14.7 months with molecular therapy versus 11 months, okay? Hazard ratio of 0.82, but not hit that less than 0.05. So those are the secondary endpoints. So the conclusions of Linda was this, that we found that molecular therapy did improve PFS compared to just platinum-based chemotherapy. We would look at OS in about a year. We didn't think that molecular therapy would increase risk or quality of life. And I think really importantly, regardless of these results in the individual subgroups, the concept was that patients living with CUP or dying with CUP deserve to have molecular profiling as much as any other patient who has got a known cancer. And we were mainly basing on foundation medicine on solid, but I'll show you later that we need to probably move to liquid biopsies, okay? So there was a change in the protocol about 1/2 or 2/3 into the study where we realized that we were failing patients because they kept saying there's not enough tissue for foundation 1, but actually they were picking up the alteration in liquid and could keep the patients on study. Now, there's lots of translational work that Ben Westphalen, who's a scientist, as well as Alvin is doing. But I'm going to show you some work that Natalie Cook at the Christie with Alicia is doing, her PhD now consultant colleague is doing, trying to do more translational work on trying to understand various parts of CUP management. And I think, lastly, we can only really think about individualized personalized treatment if there's access to not only profiling, but that you can access treatment. So let's finish talking about the study for a moment. I'm going to go into an actual patient. Probably running over a little bit. Okay, so hopefully you'll finish this in the next 5-10 minutes. So this is a patient referred to me, and he was a 70-year-old male. He has a significant history, and it's important that he carry this. He had depression and had anxiety already, and he was presented with kind of back pain. He had certainly a number of bone metastases, one specifically at T7, and also some rib mets. He had multiple liver metastases, had a liver biopsy. It was essentially CK7 positive, CK19 positive, CK20, TTF1, PSA negative. So, the question is this true CUP? Is it a cholangio? Had a normal OGD. He had all this workup before I even saw him. So a normal OGD, a PET, a CT, and MRI liver. Tumor markers, absolutely unhelpful. Okay, so the oncologist who referred to me said, look, he would like to consider this study. I've offered him carbotaxol locally. What do you think? So we reviewed it at our MDT in February 22. We made sure he had no brain metastases. He definitely had pansegmental liver metastases, which slightly went again, kind of cholangio. And I worked with Professor John Bridgewater, and I did ask him, look, do you want to put him through a cholangio trial or CUP trial? I said, no, I think this is probably a CUP, so let's go with a CUP trial. And he was symptomatic with the back pain. Just to say, you see obviously the CT scan with a lot of liver mets in the left lobe, but the PET actually showed he had avid disease throughout his liver. And obviously he has this lytic, but a non-collapsing bone metastasis, so kind of T7. And this is one of the questions, because if we were going to irradiate him, lights just went off. If we were going to irradiate him, we'd have to delay his treatment for at least 14 days. So we actually made the decision that we would just crack on and scream into study and start chemotherapy. So we didn't irradiate his bone met, and certainly not at that time. So we gave him Sysgem on a kind of lung protocol, okay? So John still felt well, treat it like a cholangio, but it's high dose cisplatin, okay? It's pretty high dose. It's not the baby dose of cisplatin. Actually, he had some response after 3 cycles. Can you see some response? Certainly, some of the left lobe has improved, but the central and central 4 has not really changed, but certainly his back pain improved. So we didn't actually have to give him any radiotherapy. Interestingly, because based on that, he got randomized into cohort 1 and randomized to MET cryotherapy. And lo and behold, he had TMB low, MSS, but he had a BRAF V600E mutation. So they're pretty straightforward, isn't it? So we're going to give him a BRAF target treatment. So we gave him vemurafenib and cobimetinib. So this is what happened, okay? This is his baseline scan, and you can clearly see he's had some response after cycle 3. It is shrinking, -17 by RECIST, but he started having a lot of side effects, okay? He had pemphigoid blistering. We had to delay his treatment, grade 2 fatigue, which we thought was from the COBI. He got eye problems, which again, we thought from the COBI. And we had to delay his treatments on and off. He even got gynecomastia, which we're not actually sure is maybe a side effect of the drugs. And we decided, look, he couldn't restart the COBI. So we actually stopped the COBI method, the MEK inhibitor, and stayed on VEM. Every day he carried on and off. And the thing I didn't say is he traveled, I think by train and from where he lived, over 2 hours to get. Now we paid for, the trial paid, the company paid for all his travel, but he had to come up the day before on a Monday to have his eye checks. He had to stay in a hotel. Then he stayed the next day for his treatment. It was pretty horrendous for him. And although I kept on saying, look, the treatment is working. So if you now see the scan at cycle 10, which is 10 months, you can clearly see, in fact, the disease is pretty much melted away. We were actually allowed to irradiate his back because he started getting all this generalized back pain, and it wasn't a target lesion. So we did eventually irradiate his back, but we weren't really sure it was helping. We just thought he was depressed. He certainly was depressed, and he just felt incredibly fatigued. So in the end, he decided, I really cannot take this anymore. I'm going to come off study. Fine, it's his choice. Well, this is what happened. So he had a PFS of 11 months on the MEK therapy, which is pretty good. Remember, that doesn't include the 3 months of workup he had. So that's already a PFS of 14 months. So he's got to PFS of 14 months with a BRAF mutated bad prognosis CUP. I just rang up the oncologist recently, and I found that she just kept him on follow-up, and she did a scan about a month later. It was fine. He was a bit breathless, but it was fine. But then 4 months later, literally a few weeks ago, he's now got significant liver progression, and he decided he doesn't want chemotherapy. He's just going to have better supportive care. So it just begs the question, what would have happened if he had stayed on target? He probably wouldn't have progressed. Again, it goes back to that one of the very first slides I showed you about quality of life. It's very important to understand quality of the patient, but much of that was driven actually by him needing to travel almost 2.5 hours each way to come to have treatment. And I've always thought that if we had been allowed to just allow him to have treatment at home, which was just a tablet, I think he may have stayed on and carried on, because it was a big, arduous thing to come up even every 2 or 4 weeks for this treatment. So this is important. I just showed you how tough the inclusion and exclusion criteria is. So it's important for the trial that we have true cuts. But is it really relevant to what we see in clinic? We really were excluding a lot of patients, and I think this is what Sally was mentioning. We've got to think there's still a population of CUP patients is not served by this trial. And I think one of the things is what I call the holy grail is we really haven't found the tissue of origin test. I think if we found the tissue of origin test, then we would put more patients back into the primary category, put them back in the GI, HPB, lung, gynae, breast, MDTs, and have that guided treatment. And really, we failed that. So there was a test, famous, called the Rosetta test, was looking at mRNA profiling. Yeah. And it was very fancy, it was very expensive, and it didn't really improve outcomes, and the company crashed. I think we've got a little bit more faith in methylation profiling. And of course, as you know, there's the GRAIL testing. And I think there's a lot of interest, and there's a lot of interest generated by the CUPISCO ESMO, but from other companies saying, hey, let's cross-fertilize our ideas here. We've got minimal residual testing. for cancers. We've got early diagnostic testing for cancers. Can we use that in the CUP setting? So it is an exciting time. And just for time, I won't go into that, but I'm sure we can cover that in questions if you wish. I just want to show you that, well, NCI, you know, has kind of imploded, but in the past many years, peri-COVID, we'd set up a separate CUP subgroup rather than it being sitting with HPV or sitting with AOS. I'm the current chair, Sally is my deputy, and we've got Claire Mitchell from the Christie, Sonali from Villandre, Aaron Kerr is a clinical oncologist at the Royal Free. We have index pathologists, radiologists, really important CUP CNSs, research methodologists, very importantly patient representative, and the only, as far as I know, well, one of the few PhD students who's now almost a consultant who did a PhD in CUP with Natalie. And we have various concepts which are all kind of imploded a bit of NCI, but we're still an active group and we're trying to work with you, everyone else, both nationally and internationally, to keep CUP in focus. And there are certain things which Sally has already showed you, you know, which are being published, and a lot of it is collaboration between the centres who the investigators or oncologists who sit in these centres. I want to show you just one which is just closed, but Natalie Cook has kind of run this fantastic kind of almost came alongside as CUPISCO was closing, called CUPComp. So this is trying to really do intensive solid as well as liquid profiling. And one was just to kind of get access to Foundation One and whole genome, and Alicia is also doing a very interesting methylation assay to try and find a primary, which she will present soon, I think. But the kind of idea was to keep the CUP community going, and we wanted profiling. And very importantly, has just finished a monthly Christie MTB where we discuss all referrals into CUPComp. And you know, although this was not an IMP trial, it got patient access to molecular profiling for free, not just Foundation One solid, but Foundation liquid, whole genome eventually, and also this methylation assay. So I think that this is a very important kind of academic study, and it's one of the few that, you know, we really got off the ground and have done very well in. So the aim was to get 150 patients. I think we've hit the 150 paired solid and liquid biopsies. And this is just actually a summary from one of Alicia's talks, which is actually maybe, especially in CUP patients, liquid biopsy is the way to go. Okay, that, you know, trying to get biopsies in patients who are not very fit or have got little areas to biopsy. Liquid biopsy is the way to help us manage our patients, prognosticate them to a degree, but also offer them treatments. So this is actually a summary, rather long, okay, of some take-home messages from Alvin Kramer, who's the CUPISCO Global Chief Investigator. He said, try to use true diagnostic algorithms to discriminate CUP from primary cancer types. What we learned from CUPComp, and we've now started CUPISCO, is that the Merck Tumor Board actually helped people not go on the trial because we found the primary. Secondly, remember those 7 favorable prognosis subgroups that Sally has mentioned, and trying to get them with good treatment, which you would normally treat for gynae, and more ideally trying to get them taken over by your specialist colleagues. In general, doublet platinum chemotherapy remains the standard treatment for poor prognosis CUP. And at the moment, until we see more translational work from CUPComp and from CUPISCO and from other centers, we don't really think gene expression profiling is technically going to help us yield better outcomes. However, the mutation analyses for targeted treatments may well hint not only for putative primary. That means if you think this could be a kind of HER2 positive gastric, you know, but we can't see the primary, there's nothing else going on, it might help you guide you to the primary. But actually, outside of those really rare subgroups, which you would try to get anyway into a clinical trial, you know, one of the questions is, does just adding immunotherapy to chemotherapy make it better? Doesn't look like it. We're going to subgroup analyze those 235 patients, but we do know that if you're TMB high, you should give them immunotherapy. Now, that's a problem in the UK and the EMA, because as you know, FDA have approved TMB 10 or more for anyone who's beyond first-line chemo to access pembrolizumab or immunotherapy. We don't really have that way of doing that yet in the UK, but we may well try and use CUPComp and something called CUPPEM, which Harpreet Wasan is doing in Imperial, to try and get maybe immunotherapy to a few more of our patients. I think it's really important to try and think about whether this patient fits the trial or fits the trial criteria. But I think it's really difficult because we still need more clinical trials. And I still think CUPISCO is probably a one in a generation study. I don't think any other company is going to take this on. We're certainly not going to do a phase 3 randomized CUPISCO, and we're just going to have to learn from the subgroups of what we can do. Just for anyone who's saying, well, how the hell am I going to profile my CUP patient? Well, there's something called Target National, okay, which is very important. Any tumor actually can access Target National, and they get free foundation testing off the back of that. And Determine Trial is another very interesting study. So I know it's running at UCL, Oxford, Christie, and a few other places. Determine Trial is about 4 arms. It's got a TMB high arm, a HER2 arm, NTRK arm, and you will get access to targeted treatments, young adults as well as adults, if you've had a molecular profile. So there is a way of profiling your CUP patients. There's also accessing IMP for CUP patients. And so in summary, we've said CUP biology is still not well understood. We definitely need MDT working and international collaboration. We've got to include our patients in involvement and feedback. But we have at least hopefully shown you, with Sally's presentation in mind, that there are novel strategies and treatments that we can offer, but we must be able to profile patients. And this picture actually is a group. You can see Sally on the left and me on the right. During ESMO, we actually had something called the World Cup Alliance. So we knew that a lot of investigators for CUPISCO were coming through, and we got not just the investigators, but Mara Stella, who's TGA CUP, to get together and really push the agenda, because CUP remains kind of hidden, we think, and we need to make sure that with patient advocacy and the scientists and the clinicians, that it remains top of the agenda, so we can still offer patients hope and good treatments. So that's my end of my talk. Thank you very much, Karim.
That's great, Kakin. Thank you both for a really, really interesting talks. And I mean, there's quite a few questions here, so I won't rabble on too much actually, so that people can get home. But I mean, I suppose I find them a really interesting cohort of patients. And one thing I always kind of confuses me somewhat is you find a primary cancer in a lot of these provisional CUP patients. You think, oh great, they've got a primary, and you send them to their primary team, or you treat them as their primary, but you don't necessarily get that response that you would hope to get if compared to, say, they were a colorectal that you just found was a colorectal from the very beginning. And just wondering why either of you or both of you think that is the way that is. Is it bad biology? Is it that it's changed too much? Have they presented too late? What do you think it might be?
I think they do present very late, Karim, and I think often they do have bad biology from the beginning. So cancers that present with their metastatic disease do seem to be particularly aggressive subtypes of cancer. We know that in all known cancer types, we also have some really bad patients with bad metastatic disease that don't respond well. And often they're the ones with the more advanced or more aggressive cancer subtypes. So I think they do have bad biology for sure, and they often present at a late stage as well. And remember, they are all presenting with metastatic disease, whereas in many primary cancers, they're presenting with a primary, and we incidentally find metastatic disease as part of their staging.
I mean, I would agree. I think, Karim, there's 2 parts. Actually, I would still say if you found the primary and it was in the colon and it's bad, it's just bad, as Sally has said, that you're taking on ages to kind of make the diagnosis. They may obviously be young and BRAF or right-sided. I think what I find more interesting is the ones who are scarred up or true unknown primary, but the molecular profile is clearly bowel or clearly lung, and yet they do badly. So I think there is this idea that there is probably some biology around not good, that you scar up your primary, but and you disseminate very quickly, and are there any kind of clonal kind of thing? So I've been trying to work before Peter Van Leeuwen moved to MD Anderson, who was a great scientist with Charlie Swanton at Crick, to see whether we could do, when we do the clonal kind of trees and going backwards, whether we would find that kind of signature of unknown primaries that either would respond to immunotherapy or indeed why problems are so bad. So I think that's what I find worrying. The ones who we clearly think are known cancer based on the metastases can't find primary, but they do badly, and that could be something which we don't understand at this time.
Yeah. Thank you. So should I just read from the top? We've got a few questions here. One of them, which forever plagues me, which Sally will knows. Andrew's asking, I get worried about making a decision about patients with a widespread or disseminated malignancy and just putting them for best supportive care without any histology, in case you've missed something, a high-grade lymphoma or a NET or something like that. And what advice can you offer on that?
So I think that's probably one of the most common questions, and I think people do really get very worried by that. I think a dying patient's a dying patient, and we have to remember that some patients, whatever their underlying diagnosis is, they are extremely advanced. Also remember that lymphomas can respond extremely well to high-dose steroids, and high-dose steroids are a treatment for lymphoma. So we haven't yet to be surprised by a lymphoma diagnosis, I can almost always predict it at our MDM and radiology. So I don't think it's very common to be surprised by a lymphoma diagnosis, and therefore we can often look at the radiology and know it's not a lymphoma. Obviously not 100% because nothing is, but you get a very good feel of what lymphomas look like. And the main areas that we see in CUP that haven't come via hematology are bone only. And so we have seen quite a lot of lymphoma in bone only, occasionally in funny peritoneal, but again, it's quite, you can kind of, the radiologists recognize it, particularly if you're in a cancer center where you've got cancer radiologists, they will have an idea. Unfortunately, quite a lot of radiologists just stick lymphoma into the differentials, and that then raises people's hopes it's lymphoma. But we have yet to find one that we think radiologically doesn't look like lymphoma, that it is a lymphoma. But the second thing is, if there is a concern that it might be lymphoma, and they may not have time to get to a biopsy, then give them a slug of steroids, and if they sit up and suddenly look great, it's probably lymphoma. And it really is a diagnostic test for some patients. I'm sure we've all through AO seen patients come in with cord compression. We don't want to start steroids until we get the biopsy off. We get the biopsy off immediately, and then we give them their high-dose steroids and radiotherapy, and actually the steroids alone, they suddenly get much better. So even before you've got the biopsy back, you know it's going to be a lymphoma. So lymphomas are really steroid sensitive, and I think that's a helpful diagnostic test if there's diagnostic uncertainty. If you don't want to put them through a biopsy and things, you're concerned they're going to go downhill really quickly, give them steroids, and if they miraculously recover, it might be lymphoma, and then you want to push on with investigations.
Yeah, I agree. I mean, I would only add, I've never been surprised in lymphoma, but I was taught by our hematologist that you can give up to 72 hours of steroids, and then in that window you could do a biopsy. Obviously, after 70 hours, you may start losing quality, but if needs must, SVCO, cord compressions, just do it. But I think generally, yeah, and I've actually seen our hematologists give vincristine on ITU with no tissue diagnosis. I mean, it's quite amazing what the hematologists do. So I would involve the hematologist. I think most of the stuff we disseminated, as Andrew said, it's a lot worse. It's disseminated, bone, brain, peritoneal disease. That's not lymphoma in general, so yeah.
Thank you. And then another, probably two questions they're asking similar, probably for Kaikin as well. What molecular profiling are you sending for CUP patients off trial? And then can we send whole genome sequencing upfront at the time of diagnosis? And is it approved on the NHS in England, for which it definitely isn't in Scotland?
Yeah, so, and well, for good or bad, you've heard about the kind of test directory for lots of tumors, and we're trying to get CUP to go beyond whole genome. So for some crazy reason that Sally and Natalie cannot understand, they've approved whole genome testing for CUP patients. But how many patients honestly have enough tissue to send for whole genome? And even then, it's not a validated test. You'd have to validate, any findings on something else. So what Natalie's trying very hard to do, and we're trying to support, is actually say, look, it's massively expensive to do Illumina arrays, and why don't we just fund at least a liquid biopsy? It could be commercial test or something like that, because that's usually more helpful. And this is what CUPComp and the CUPISCO has shown, funding and I don't know because it's variable. Okay, I'm going to be very careful what I say. But, commercially, private sector land to do a liquid biopsy for FM1 costs about £3,500. But I know, that the NHS price is about £1,500 or less. Now, that's still expensive, but there are some CCGs out there who are funding that. And they fund it for lung cancer now and things like that. So why not fund it for a CUP patient? That's what I'd say. I also have patients who self-fund garden tests and things like that. I know that's not always feasible, but beyond first-line chemotherapy, which I think I'll talk about, that question about induction chemo versus upfront, actually, what have they got to lose? Actually, we have seen, and we've seen this in cholangios now, that you see these really rare things. You see BRAF, you see kind of MET, you see really unusual mutations. And I predicate that, as Sally said, these are already motivated, fit patients, or you have to get them in early before they fall off the perch and become very, very unwell. But yeah, it is tricky. Yeah, I do not say it's easy to do MET profiling. I think that hopefully within your cancer or within your cancer MDT, there will be some things that you can do, and some of them are really transformative. Obviously, MMR deficiency, is important. HER2, simple things that you can have easy access to is important. The rare stuff, you have to try and use your nous to kind of get that profiling. Did you have a second? There was about, we talked about whole genome sequencing. Yeah, you can, but it's super crazy difficult. I think I just wanted to say something about why would you go straight into, there was some question about induction chemo.
Why would you give the induction, or why would you not just go straight to
maybe
target?
I will answer this as well, because I think I was there. So there was a massive debate when the study was thought about. Okay, it was a really interesting thing, because although Roche funded the study, okay, it was actually thought about by people like Linda Milliskin, Richard Totho in Australia, Harpreet Rasan, Alvin in Germany. These were academics, okay, who said, look, we have these concepts of giving chemo and then finding a profile, and then N=1 arm study. And they said, well, why don't we just try and bring it all together? Okay. And there was this thought, and the Americans didn't buy into this. Just so you can see that the Americans, a guy called Tony Greco, didn't buy into this, because he believed that everyone should have MET profiling up front and just go straight into targeted treatment. But we were worried in this context of the study across many nations, where we were going across nations that are not as advanced, I must say, as America, or indeed the UK or parts of Europe, that induction chemo wasn't wrong, to try to get an early response. And even if we've learned from immunotherapy, upfront immunotherapy, even if your TMB high, could be a slow response. So it wasn't wrong. I think in reality, if this trial was ever going to come into reality, is that we wouldn't necessarily give 3 cycles of chemo. I'm not sure how Sally, but I certainly had 2 people who stopped chemo after 2 cycles because they just couldn't take it. They could stay on study, but you could argue 1 or 2 cycles of chemo induction whilst you get the profile back, because the trial obviously released the profile after you responded. But in reality, you get this profile within, I don't know, 10, 15 working days of sending off the profile. So I think that we wouldn't necessarily give that much induction chemo if we had access to profiling. That's my general feeling. Sally, do you want to comment on that?
Yeah, I mean, I think one advantage, as you allude to, Kahin, is the time that it gives you to get profiling back and make a decision on an MTB and so on. So there was an advantage sort of practically in starting off with chemo. And we do know that, particularly in aggressive cancer types, sometimes sort of getting control of the cancer with cytotoxics is quite helpful before more targeted approaches. So, but it remains a question, and the question hasn't been answered with this trial, I'm afraid. Yeah.
Perfect. Thank you both very much. I think we're a bit short on time, but what I'll do is I'll copy all of these questions and I'll email Kahin and Sally and get a response and email you back with it, if that is okay. Thank you very, very much for your time. Very much appreciated. Really great talks. And if anybody else has any questions, please feel free to email myself or Richard, or I'm sure Kahin or Sally would take your questions as well.
For sure.
Thank you.
Thank you, everyone.
Thank you.
Take care, everyone.
Bye-bye.